before we get into this week's Nurses Uncorked, we want to give a shout out to Erica. You're going to love this. Ativan.
No. What's up, Ativan? Welcome.
That is our newest patron. That makes 24 patrons. Welcome, Ativan, to the patron community for Nurses Uncorked. And the next person that becomes a patron, the link is in the description, will be the one that tips the scales. And we will be doing our big giveaway, right, Erica?
3 giveaways, 3 separate winners once we hit 25. We're almost there, guys.
Yeah, I can't wait. Hopefully on the next podcast, we'll be announcing the giveaway. That's going to be awesome. Thank you, Ativan. So
thank you.
This week's Nurses Uncorked, we want to thank our sponsors, is brought to you by Vivian Health and also by Stink Balm Odor Blocker. I'm Nurse Jessica Seitz, along with Nurse Erica. We're Nurses Uncorked, the podcast that takes nursing facts with nursing comedy and makes a little cocktail out of it. We're here again. It's myself, Nurse Jessica, Nurse Erica. She's all smiles today. I love it.
Because we're doing an important topic, and I think this is going to be really helpful for nurses out there.
It is. We are covering today patient abandonment, which is a topic that nurses have had a lot of questions about, So we're going to just get right into it after our drink of the week.
Cocktail of the week.
Yeah.
Yes.
Woo.
Okay, so it's nothing complicated, but it's one that I've been wanting to try for a really long time. Y'all know I'm a Moscato queen. I love Moscato. And I saw this one in the store. It's tropical blueberry Moscato. And that sounded
looks pretty.
I know, right? It just sounded so good to me. So it's nothing fancy. It's got a screw top, but I've been excited to save this.
The screw top thing is getting
because
really good
there's a
wines
cork
with it.
shortage. Did you know that?
Oh.
So that's why. So a lot of
I did not.
more expensive, fancier brands have had to go to screw tops because there's been a cork shortage. Why? I don't know.
I did not know that, but
yeah,
I'm curious to know how it is. I'm sure it's going to be good. I can't imagine it's not.
Oh, that's good.
Cheers.
You can taste the blueberry. Cheers.
Yeah.
That's really, really good. Really, really
cheers
good.
To
I love my Moscato.
Patient abandonment. No, I'm just kidding. I don't think we want to cheers to that. But
cheers to all the nurses that get threatened with patient abandonment. Let's give you some education so you can empower yourself today.
Let's start with as we drink our wine. I've got my Chardonnay. I'll get into what the definition of patient abandonment is. Okay. So I was researching all day long on this. Whew, I've got it all ready to go. All right. The ANA defines patient abandonment as a unilateral severance of the established nurse-to-patient relationship without giving reasonable notice to the appropriate person so that arrangements can be made for the continuation of nursing care by others. It can be intentional or inadvertent. So it can be on purpose or not on purpose, but I guess if you abandon the patient, that's patient abandonment. Do you think that's a vague definition, or do you think that's...
I think it's kind of a catch-all, and a lot of the individual state boards of nursing and nursing associations have kind of adopted that since it's from the ANA. So, that's a pretty good definition. I think a lot of people assume that it's only applies to hospitals, patient abandonment, and it doesn't. It applies to all healthcare settings, of course, long-term care, rehab, but also home health and hospice. You can't just abruptly stop seeing your patients. You are obligated to give them advance notice, usually like 30 days or so that they can obtain other nursing and medical care. So it's really across the board with all healthcare settings.
I'm going to learn a lot from this episode. I can already tell, because I would not have thought that. I would have thought as long as you quit but didn't start your day, like that would be not considered patient abandonment. Like,
I mean,
tricky.
That is a little tricky. Yeah. No, you can't just stop seeing them without arranging for other nursing care to be in place or giving them notice so that they can get other nursing care in place.
Okay. I have lots of questions, but we'll
That's all right.
Well, we're gonna get into it, and I don't think I'm the only nurse that has that kind of questions, because
it's
that's
so
the fear.
Misunderstood.
It is. It's a fear of nurses, is I don't want to be accused of patient abandonment. Like, we all say it, but do we really know what the hell we're talking about? Do we really know what we could get in trouble for?
And I want to point out, I want to say up front, I am not an attorney. You are not an attorney. We are not legal nurse consultants.
Oh, clearly not.
Clearly not. This is solely based on my experience, my knowledge, and my research. And it does differ state to state. So you always need to be familiar with your individual state. Nurse Practice Act, scope of practice, Board of Nursing, physician statements, all that good stuff. But yeah, we are not legal experts, but I think that this is going to be a lot of really helpful information for nurses.
Okay, definitely. All right. There are consequences for patient abandonment. Yeah. So you can be terminated from your job. That's obviously a big one. You could be fired. The Board of Nursing could put you on probation or suspend or revoke your license. Ooh, that's an extreme one.
Scary.
Yes, very scary. The patient could sue you for medical malpractice if they feel their abandonment caused them harm. Mm-hmm. So, all three are actually scary consequences, to be honest with you. I think the last two are a little scarier to me.
I agree.
Your license for being
And it's
sued.
important to point out that boards of nursing, they have no jurisdiction over employment issues. So you can be terminated from your job, and the Board of Nursing can separately be investigating you for patient abandonment. The Board of Nursing can find in your favor that you were not guilty of patient abandonment, but they still have no jurisdiction or purview over the employment side of it. So it's important to understand that. But
so if they favor in your on your defense and say it wasn't patient abandonment, they can't force your employer to hire you back and say, oops. Okay.
Correct.
That's good
to know. And they
actually
typically go to great lengths to separate themselves and say, like, employment is one area and that's not ours. So, don't expect us to get you your job back, basically. That's not their thing.
I guess you'd have to seek legal counsel if that's what you were going to fight for. Yeah.
Yeah. And also, it's not just RNs and LPNs. I think a lot of people assume that. This also applies to like APRNs, NPs, nursing students in some cases, and CNAs. And I don't think that's very well known. So in the case of APRNs or NPs, they cannot, for example, refuse to see patients because perhaps that patient failed to pay for previous medical services. That would be considered a form of patient abandonment if they are not giving them enough notice to seek care elsewhere. In the case of CNAs, it's not very common because they're not licensed. However, if them abandoning a patient results in patient harm, there can be recourse for that. They can be reported to the boards of nursing, depending on the state. Their certification can be in jeopardy, and potentially there could be civil action. And in the case of nursing students, again, not very common. But if a nursing student, for example, goes off the unit to go get lunch, or at the end of the day to go to post-conference, and they fail to inform the assigned nurse, the RN or the LPN, and that nurse assumes that the nursing student is still there providing some sort of necessary care, and there's harm that results, that can come back on the student and the nursing school and the licensed nurse and the facility. So everybody needs to be aware of this and be really careful.
Cover your bases, man. Make sure that whoever the nurse is or your clinical instructor, both of them, know and they're on board with what you're doing. Don't
just communicate.
Don't assume, because you can make an ass out of you and me.
That's very wise.
Yes, a wise nurse once said. Yeah. You know what I was thinking was, so how does the Board of Nursing find out? Your employer reports you? Like they fire you, but then they report you to the board? Because
typically,
that's how...
Yeah, or they don't fire you, but they still report you. Yeah.
Okay. I'd be really pissed.
Especially if it wasn't...
Is it? Oh, are you serious? Oh, we need to hear that story today.
Yeah. It has.
Do you want to tell it now or later?
I'll tell it now. Yeah. It's a long story, but I'll keep it really brief. So I refused a patient, not the whole assignment, but a specific patient. It was a general peds unit, and it was clearly an ICU level of patient. They were in acute DIC, like out of every orifice. They were circling the drain rapidly. So inappropriate.
So wait, is this a patient you've ever taken care of this type?
I had them the day before, 12 hours prior. So I knew the patient very well.
Okay.
But I also knew how to do it appropriately. So as soon as I saw my name by that patient on the assignment sheet, I immediately said, stop, I'm not taking a report. Hold on. Because I knew once I started to get report, it'd be over and I'd be obligated to take care of that patient. So I went to the charge nurse, said, hey, this situation, this is unsafe. He really needs to be upgraded, blah, blah, blah.
Okay.
Charge nurse went rogue on me and said, oh, you're refusing? Let me get the manager on the phone.
Oh boy.
Skipped steps 2 through 9 and went straight to 10. Gets the manager on the phone. Long story short, manager, Cindy, I'm just going to call it like it is. Cindy, you are an absolute nightmare. And what you did was wrong and you did me dirty. Cindy. We all know Cindy. Okay.
Is Cindy getting the enema this week?
No, she should, honestly. We could change it. But she said she was still at home. It was like 7 a.m. And she said, nobody leaves till I get there. Like she was holding night shift hostage because in her mind, she thought everyone's going to be pissed at me that they can't leave. Well, they weren't. If they were, they didn't express it to me. I think they all agreed with me and they all supported me. But it sucked. And her ass didn't show up till like 9:30. 9:30.
Oh,
yes.
Night shift had to be pissed, man.
I'm sure, pissed. But like she did that on purpose. Absolutely did that on purpose, right? So then she comes in and she's like, let's sit down and talk about it, Erica. So I go through the whole thing, why he's not safe.
The condescending voice, yes. Cindy.
Yes, exactly. And she's like, well, Erica, I'll be here to support you. I'm like, Cindy, you haven't touched a patient in 20 years. I'm sorry. How is that helpful?
I'm going to support you from my office, Erica. I will be here in my chair.
And she's like, let's go through the plan of care. You tell me what you're not comfortable with, why you feel that you're not competent. And I said, oh, I'm very competent. But I'm telling you, he's a 1-to-1 right now. He's probably going to code any minute now.
Because he's bleeding out of his ear holes.
Literally everywhere. And you want me to take him and I think it was 5 other patients?
Oh,
absolutely not. Right? It was so egregiously unsafe. But she just kept condescending, patronizing.
That should have been a one-on-one. Like, if they were going to do it. If they were going to do it. At least let that be your whole focus. Where like, oh, that's off. So the day before, they were in a completely different state. They were
they were still terrible. Yeah, I was trying not to get to the long story, but briefly, they were terrible. And I had them upgraded to ICU, which was a whole ordeal. And the medical director wanted to empty out the ICU and inappropriately overnight. So they claimed that, in those 12 intervening hours, he somehow had a miraculous recovery and was now totally appropriate for the unit, which he was not. Nothing had really changed.
You knew better. Yeah.
I knew better.
Okay. Gotcha.
And so I'm sitting down with Cindy for probably an hour and a half. We go back and forth and she won't let night shift leave. It was terrible. And she's condescending me and patronizing me. And we're going back and forth. And I stood my ground. And finally, after like an hour and a half of this hell, she said, okay, you can clock out and leave. So I did.
Oh, God.
And then I
were you like, what does that mean?
I was freaking out inside. Yeah. Yeah. And she's like, we'll be in touch. She wouldn't give me any information. She's, Cindy, you absolutely suck. Anyway, so she calls me later that day and tells me I'm suspended pending an investigation. It's a whole thing. It was a unionized facility. I reached out to, the union advocate to represent me, but basically I had to wait for like a week, unpaid, while all this was going on. Finally go back. We have meetings in HR.
Okay.
It's found in my favor. I did nothing wrong.
Good.
I go back to work. They pay me for my time that I was off.
Good. Oh, good.
And,
although you probably had a knot in your stomach that whole week.
Oh, it was terrible. It was terrible.
Yeah.
It was awful. And I was a single mom. Like, it's my only income.
Yeah.
You know, I was freaking out. Yeah, it was awful. And I think, okay, it's done. I won, victorious. Woo! Go back to work. And probably 5 weeks later, I'm home one day and there's a knock at the door. And it's the mailman with a certified letter from the Board of Nursing saying that I have been reported. She didn't even tell me, didn't even give me the courtesy of a heads up. It was terrible. This led to like horrible. That was my horrible year when I turned 40 that I talk about, where like a million things went wrong. That was part of it. Yeah, it drug on forever.
So you had to keep working there knowing now that even though they realized, they said you weren't at fault, but it was too late, she reported you to the board. Oh, I would have wanted to.
Yeah.
I would have wanted to.
And so when I saw her the next time that I worked,
something to her.
After that, I followed her into the bathroom, into the locker room. And I'm like, Cindy, you reported me to the Board of Nursing? And she said, and I quote, Erica, I don't operate in a silo. And I'm like, I don't know what does that mean, Cindy? What does that mean?
Okay, good. Because I didn't know what it meant. I didn't know what the hell that meant. I was
she said, it's not always just my decision. Basically, she was trying to say it wasn't her fault that someone made her do it. May or may not be true. I tend to think it was her idea. But regardless, it happened. And it should never have happened. Eventually, long story short, the Board of Nursing investigated and it was cleared 100%. They even sent like a letter of admonishment to the hospital saying, I'm paraphrasing, you knew damn well this was not really patient abandonment. Why are you tying up our time and resources to investigate something? This was a frivolous claim, basically. So, I mean, I won, but it was hell. It was absolutely hell.
Now, wait, this leads me to think, if you start accepting report, is that a different story? Like, what if you start listening to report, but then realize as you're getting report that this is not safe?
That's like, very complicated. Yeah. If you are already getting report, you have established a nurse-patient relationship. Even if you haven't seen the patient yet, doesn't matter. So now you are ultimately responsible. Now, what you can do is stop report, go to the charge nurse and try to get them to change the assignment, to do something. If they're refusing, like Marlene, you're also not a nice person, Marlene, who jumped on the phone with the manager. I'm just going to call y'all out today.
Marlene and Cindy. Woo! Not on Erica's good list.
I don't know why she did that. Honestly, I felt like I was set up, but that's another story. You should then create your paper trail, do an assignment despite objection, a protest of assignment, whatever kind of reporting form you have to document it there, or just put it all in an email to your manager, your charge nurse. You could also reach out to the house supervisor. Just keep saying it's unsafe. I am like accepting this under duress because I've already started getting report, but it's clear this patient is not appropriate or it's whatever. But yeah, you then really do need to move forward because you have established that nurse-patient relationship. So if you are ever in doubt,
that condescendingness, like I'm just picturing what is it that you're not comfortable with exactly?
Yeah, that's what she did. It was terrible. She gets the chart out saying that because this is like hard chart days, not EMRs. And she's like going through it. Well, is it this order that you're not comfortable with? Can you not draw the cultures? No, I can do all of that, Cindy, but I can't do all of that with 5 other patients. What part do you not understand?
Exactly. So what ended up happening? Who took the patient once they sent you home?
I really don't know. Actually, I went home and I would be willing to bet that another nurse just took it because, nurses often don't stand up for themselves like they should, but I don't know for certain. But yeah, so don't establish a nurse-patient relationship. That means do not enter the medical record, no digital footprint, do not go in the patient's room, do not accept any report, do not ask the previous shift nurse anything about the patient if you already know that you're going to be refusing it. so that you can safely say, I have not received report.
And some people might say, well, how would you know you're going to refuse it if you don't even hear the specifics? But there could be other circumstances, like your ratio could just be not safe.
Yes.
Like,
just numbers alone, it could be inappropriate. Right. In my case, I knew the patient.
Yeah. So there are other circumstances where you might know some details, but it's before you have accepted or heard.
And employers have gotten really sneaky where they won't let you see the assignment until like you've clocked in. So you can't do the whole I haven't even clocked in yet thing. They purposely set it up that way. They are trying to force us into situations. And so in that case, if you have an employer that does that, I think both shifts need to communicate really well. And you need to have people that you trust on the opposite shift that, when you're on your way to work, you can, maybe text, call and say, hey, what is it today? Like, how many have they given me? So that at least you can walk in somewhat aware of what's going on, but it's precarious. It's very precarious. Yeah.
Well, I think you have actually shared that with me briefly at one point. Now that you're telling me, I kind of remember, but I didn't realize that. I mean, DIC is scary in of itself.
It was so scary. It was, you can't leave the room. You're covered in blood. It was terrible. Terrible. Yeah.
Oh, what a mess.
Yeah.
Okay. For patient abandonment to occur, you generally need the components as follows. You must have an established nurse-to-patient relationship. We talked about that. The nurse leaves an assignment without informing anyone. Okay, so you don't pass off or tell anyone, report or anything. No communication handoff or contingency is arranged. The patient still requires care, but is left without a nurse, or no attempts to replace with another licensed nurse, I guess, if that has occurred.
Yeah. And in general, it's going to switch, a little nuanced state to state, but in general, those are the components. So I thought we could go through a list of some things that are considered patient abandonment. Some will be obvious, and I think some will shock you. And then we can go through a list of what's not considered patient abandonment that they use to manipulate nurses at the end.
Okay.
But it's also important to point out that a lot of these can also be considered professional misconduct by the Board of Nursing. So you can be charged with both in some situations, patient abandonment and professional misconduct. Yeah.
All right. Before we get into more of these, let's take a break and listen to a quick word from our sponsors. I'm doing a call of action and asking everybody to support one of our fellow nurses, an ER nurse that has created her own business. We all should be stepping up to the plate and supporting one another. We have an ER nurse that has created her own company, and she has developed a lip balm. Well, it's kind of like a lip balm, but it's not for your lips. It's a stink balm is what it's called, and it's to eliminate odors. Tell them about our favorite, Erica, Evergreen.
Evergreen is my favorite scent, but there's so many different scents, and you just rub a little bit under your nose. It's tiny. It looks like a chapstick in your pocket, and it blocks all of the horrendous odors that we are exposed to, and it's very discreet. So patients don't know that you're doing it. You're not having to spray room fresheners in front of them or any of that. You just put a little dab under your nose. It's great.
And as the kind nurse that she is, she's offering 15% discount off of your total by using Uncorked 15. You can get 15% off. And like Eric was saying, so many other scents. You should definitely check it out. Stinkbombodor.com. The link is in the podcast. Attention to all of my overtime healthcare workers. If you are one of these nurses or healthcare workers that relies on overtime, but your facility is just being stingy and not giving it out, we have the app for you, the Vivian Health app. It is a job marketplace for everyone, not just nurses.
Yeah, no need to juggle multiple job sites. You can just go to Vivian Health. They have full-time, part-time, per diem, travel, local travel, everything all in one place.
And it organizes your pay based on highest to lowest paying jobs. It's amazing. Check out Vivian Health app. Download it today. The link is in the description also of this podcast. All right, we're back. Let's hear what is considered patient abandonment.
Leaving the unit, like for coffee, for lunch, anything, without notifying a licensed nurse and arranging coverage.
Okay.
That's kind of obvious.
Yeah. Yeah.
Right.
I think most people know that.
Yeah. Leaving a restrained patient alone in a room in some states can be construed as patient abandonment. Isn't that crazy?
Especially if they're deemed to be like a one-on-one where they have to have care and you step out of the room for whatever reason. I'm trying to
it's bad enough like you have to go in there every 15 minutes to check on them, right? When they're restrained and document. But you can't leave them alone in a room?
I don't know much about restraints. Like L&D,
you haven't had to do that, have you?
I don't. Yeah, that's why I was just about to say I don't even know what typical
it sucks. It's so much documentation. It's a lot. It's a lot of work. But yeah, I think people are surprised by that one. Working while impaired in any way because you cannot safely provide nursing care, theoretically. So under the influence of alcohol, prescription meds, even drugs, anything like that. That can be a form of patient abandonment.
I had one nurse that had recently been diagnosed like with anxiety, and it was the same. She had a prescription for Xanax from her doctor and was taking it, but she was there slurring her words and like falling asleep. It was bad. I mean, she ended up taking a leave of absence. Like I think it was kind of forced somewhat until she could get regulated, but luckily didn't lose her job or anything. But I think it was kind of those same circumstances. Like it was like, this is embarrassing. Like I mean,
that's so bad.
Yeah. So I
mean, it's not safe. That's a safety issue.
Yes, she had a prescription technically, but it was having a severe effect on her where it was making her sluggish.
Impairing her. Yeah.
Yeah.
Think about it. Where would her reflexes and responses have been as acute as they normally would be? Probably not.
Hell no. She couldn't even hold a conversation.
Well, there you go.
I don't think she had reflexes of a cat. I can tell you that. It was more of a sloth, something along those lines.
That's so bad.
Yeah, it is. It was. Yeah, it was bad.
All right. This one always shocks people. In some states, quite a few actually, sleeping at work is considered a form of patient abandonment, even if you're on your break. And people get so pissed when I say this. They're like, that's not true. We do it all the time. Yeah, a lot of places and a lot of people do a lot of things all the time. But that doesn't change the fact that it can be considered a form of patient abandonment. And believe me, I used to sleep on night shift in my first job as a new grad, and we all kind of did it. We had couches in our break room. We would sign off. But
what difference does it make if somebody's covering you? If you want to take your 30 minutes to have a little snoozy woozy.
I agree. But in some states, I think originally it was probably meant for someone that is not on break, that is caught sleeping at work. But it has been applied in cases where just sleeping at all.
It's kind of like it's one of those things of stretching the definition has not been like further explained. So I think you can interpret it how you want, kind of thing. Yeah. So be careful then, I guess, what state you're in as to what the sleeping rule.
I know, it's crazy. And kind of related to that is sleep deprivation. This is a big one because, again, you cannot safely provide nursing care. It's a type of physical impairment. And so what we find is that, nurses are pushed and pressured to take all these overtime shifts because they're so severely understaffed and they don't want to. But here you are on your 6th 12 in a row and you are sleep deprived. Is it your fault? Not really, but it is. Because you know that you're sleep deprived. You know that you are not going to be thinking as clearly as you normally would.
Right.
That can be a form of patient abandonment.
You know what I was thinking? And I wonder if you know the answer to this. So, okay, for example, let's say you quickly wanted to go get a cup of coffee, right? Mm-hmm. And you ask your buddy, Susie, can you just listen out for 5 minutes while I go run and grab coffee at the coffee shop? If you didn't chart it and then something happens and Susie denies that she was watching that patient. Like, that's one of those things that I have always heard is like, you go on lunch and somebody assumes care, you better chart it. Report given to blah, blah, blah. That's a tough one, because if somebody wants to be crappy and somebody went south and then they say, oh, I wasn't listening out. If you didn't write it, I don't know.
That's hard, because that's so much work. It's one, especially if you have numerous patients, it's one thing to write it for like shift change, gave report to so-and-so. It's another thing to write it for lunch break, but then to write it for a 5, 10, 15 minute break,
a piss break. I gotta pee.
Much.
Can you listen out?
I honestly have never done that for just a quick break. I have not either, but I have gotten into the situation where somebody was supposed to be listening out. We didn't really write the other nurse's name on the census board, and then your patient calls out and the secretary's like, can't find you, and then they think like nobody was listening, but the nurse that was supposed to be is in another. You just need to be careful is all I'm saying. Like, you think it happens.
You think that somebody's really listening out, I would just make sure somebody knows. If it's like the unit secretary, the one that's hitting the call, something.
Yeah, exactly. That's what I always would do. Yeah. As you're walking out, tell the unit secretary and or the charge nurse, hey, gave report to Barbara. I'll be back in 15. Providing incompetent care, not adhering to established evidence-based practice. So doing a procedure incorrectly, maybe like a sterile technique that you are not sterile, something along those lines, can in some cases be a form of patient abandonment. Isn't that crazy?
It is, because I would just think that that's like more like nursing, not malpractice, but you know what I'm trying to say.
Professional misconduct. That's what I'm saying. A lot of these can also be professional misconduct. Yeah.
Yeah, that's where my brain would go, is that that's more of what it is. But who knows? I guess it can all fall into both categories, I guess.
Here's another one that I think will shock people, that I think is so important. Failure to assess your patients. Failing to assess your patients can be a form of patient abandonment.
That makes more sense to me than some of the other ones.
Yeah.
Honestly.
This is a big deal lately, because I have to tell you, it's really an issue with me. There's a lot of nurses out there, I think really since COVID especially, that have just stopped assessing patients. They're not carrying stethoscopes. They're not even doing their basic once per shift. I mean, there's no excuse.
The nurse that charts pedal pulses equal bilaterally on the double amputee.
On the bilateral amputee? Yeah.
Yeah. Like that, girl. Right there. Yeah. I could see that. I definitely could see that. I could see why some people wouldn't think of that like in their mind, but I understand it.
Yeah. Failure to report critical lab or test results to the provider can be a form of patient abandonment. Okay. Failing to report abuse or neglect that you're aware of, because we're mandated reporters, can be construed as a form of patient abandonment. Failure to perform assigned responsibilities. And this seems a little, I think what they mean is maybe failing to carry out the provider's orders, but this gets complicated because you're obligated to not do something if and you feel an order is really inappropriate, right? So it's like a case-by-case situation. They're going to have to, investigate. But in some cases, that can be a form of patient abandonment.
Don't just opt to not do it because you think it's dumb. Right. Follow your chain of command and
document it.
Yeah, and explain what's going on. Just be careful with that.
Yeah. Leaving an emergency situation. So like your patient is coding and you just walk out of the room. Patient abandonment.
That's
but I mean,
that's That sounds like something evil, man. That sounds like jail time. Oh,
I've seen a nurse do that, and it wasn't malicious. It was like they freaked out. I don't think they had ever been in a code before. And they just freaked out and like walked out. And I'm like, what are you doing?
I don't know. I don't know what I'm doing.
They just kept walking. It was crazy.
Okay.
Giving report to an unlicensed or unqualified person. So a licensed nurse cannot hand off report to a CNA or to
come on, dumbasses.
Radiology. Like if you're dropping the patient off and they need to be with a nurse, depending on their situation, that's not a licensed nurse. That is not appropriate handoff. No.
Yeah. And you know what? Sometimes they put pressure on you from the unit. Like,
yes.
Well, while they're there, while they're getting x-rays, while they're blah, blah, blah.
We'll watch them for you. It's fine. Yeah.
Yeah.
And sometimes it is. But depending on the patient.
Is not allowed to be left alone or left without a nurse's. Yeah. That's good. That's a good one.
Yeah. Failing to communicate significant changes. So your patient has a change in condition that's important, that's significant, and you don't inform the provider or the charge nurse or anyone, can be a form of patient abandonment.
Your patient's turning blue and you're just like, oh, that's some pretty makeup they have on.
Yeah.
I love that shade all over their face. Anywho, yeah.
Failing to document. That's a big one. I don't think people realize that can be a form of patient abandonment. If you are, for whatever reason, failing to document important things or at all.
If you didn't chart it, you didn't do it. If you didn't chart it, you didn't do it. So it can be construed as you didn't do it.
Yeah. Failure to inform the patient where they're going. That's kind of crazy, right? And it doesn't specify, but I think it means like if you're transferring to another unit or facility, something, or going home, and you don't, it's a little vague.
What about the patient dumping, where they put them in the wheelchair and leave them on the side of the busy intersection?
For sure, definitely.
That could be patient abandonment for sure.
Well, and that's my last one on the list, was discharging a patient too soon. Discharging a patient that you know is not safe to be discharged. And that's so hard because nurses run into this all the time. And the doctor is ordering it, and the charge nurse and everyone is forcing the patient out. And it's like, what do you do? But in some cases, that can be construed as patient abandonment. So use this kind of stuff as motivation to do the hard things and advocate for your patient, because it could come back on you in ways that you don't think.
Document that you did not agree with this. You notified A, B, C, and D. Document all your education that you did with the patient, like, so that if they are discharged too soon and A, B, and C happens to them, that you've told them what signs to look for.
Right.
Cover all those bases. Yeah.
Yeah.
Ooh, that's scary.
Do we have a problem of the week, Jessica?
We do.
Problem of the week.
I'm going to report this one anonymously, as most people that turn in their problems do that. But this was given to us this week. And this message I got says, ladies, I think I've dug myself into a grave. I've been with my organization since I was a nursing LVN student, and now it's like, how do I diverse myself? Just venting. So basically, I think what they're saying is that I happen to know this person slightly. They have furthered their education, okay, but they've been kind of with the same place the entire time since they began, okay, and they're moving on now, but all of their stuff is kind of like basic stuff in one area. How can you make yourself appear more appealing, I guess, now that you are going to start seeking employment, possibly somewhere else? Does that make sense?
I think so. I will tell you that some of the most dangerous nurses I've ever worked with have only ever worked in one hospital their whole career.
Oh
and
my
they
God,
don't
that's
know
me.
that they're dangerous.
Well, that's me. I'm the danger. I'm a creature of habit. And I like when I'm comfortable somewhere.
Yeah.
Like,
I mean, you do get into your comfort zone. Absolutely.
But well, I mean, looking, this person also sent me their resume. Okay, so let's get a little more detailed here so that we understand it better. And I haven't reviewed.
Sent you the resume and everything.
Yeah. Yeah, you people think we just make this shit up, don't you? No, this is real life problems here. Okay. So they currently have their masters now. They got their masters. But they've had their bachelor's, it appears, for about a year and a half, 2 years. Their AA for the last 3 years. But they've been, I guess, at the same place since they were a nursing student, since way back in the day, since 2014. So same place, haven't worked anywhere else. And I have a feeling this person will probably get a job, no problem. But I think that they're probably concerned that it's like, hey, okay, this is what I've done. Like, what do I write as my skills? What am You're good at this resume writing thing, aren't you, Erica?
I am good at resumes. I'm so good at resumes.
Not that we're plugging Erica's resume writing business or anything. I don't know how we segued into that.
You did it.
I know. I set myself up for that. But I think you've got to be creative too. You've got to be creative in what you have done at that established place that can seem diverse. I would assume that
you can, in your job description, you can say frequently floated to X unit, ABC unit, cross utilized in this unit, and then talk about it when you have interviews as well. Different certifications. All I
have to say is that this person, and they know who they are because I got their permission to share this anonymously. You are not going to have a problem getting a job. I'm reading all of this and I'm like, why are we so critical on ourselves as nurses? Seriously. I mean,
we are.
ACLS, BLS, PALS, BLS instructor, certified ambulatory care preceptor. Like,
oh, that's good.
There's leadership and mentoring, experience in mentoring. I think that nurses are
they trying to get into like critical care or something that they haven't done before? Maybe is that what they're worried about?
I don't have that specifically from them, but I think I would assume so because they just got their master's. I think that maybe they're moving on to
maybe leadership or something, and then they're having imposter syndrome, which is so common. That could be it.
I would just say, based on what I'm reading, I think that this person's being critical and hard on themselves, which many of us do. I mean, but yeah. The only way to diversify yourself anymore is if you apply for the position you're wanting and you don't get it based on they don't feel like you have enough, maybe sadly you have to take a position at a different, like it may not be the position you want that's, based off of your master's degree, but you might have to do that if
you can get your foot in the door in the facility you want to be in. And then start, just reach out to the other unit's manager and say, hey, I'm interested in coming here, in 6 months or a year, whenever I am allowed to transfer. I would love to float here and gain some experience. If you ever need help, here's my number. They'll call you eventually. There's going to be a day where they need help.
But I think based on everything else, and I know this person says they're just venting, but I would say you're doing everything that you're supposed to do. I mean, all you can do is try to be as descriptive as you can with what you've done already. And they appear that they've done that. And worst case scenario, which I know you don't want to hear that, is like Erica was saying, take a 6 months to a year job in maybe that facility or a different area that you think would benefit and make you more appealing to the job that you really want.
Yeah.
I hope that sums it up.
They'll be fine.
I know they will.
All right. Let's do a list of what's not considered patient abandonment, because these are things that are used as threats against nurses all the time. And they're told, if you do this, we will report you for patient abandonment.
Passing gas and blaming it on the patient is not a form of patient abandonment. That's a good one.
That is a good one. All right.
Not that I've never done that. Never.
Not showing up to work. No call, no show. You could get fired. It sucks, but that is not patient abandonment. You have not established a nurse-patient relationship.
That scares a lot of nurses more than anything. There's no call, no show. That's bad.
I know. It is. It is bad, but it's not patient abandonment.
Okay.
Quitting a job without notice. This is a big one. You tell them, I'm done. Like, you have the shift from hell and you're like, I'm done. I'm not coming back. As long as you're finishing your shift, you're not leaving mid-shift, right?
Wait a minute, but does that cover the people that do home health?
Well, yeah, because that's a little different. Yeah, you have to absolutely inform them, and you have to, in that case, if it's home health, you're at the end of your day, you decide you're going to quit, you need to call your manager, whoever
because
the director
there is no
and
backup
say,
person.
I'm not going to be there tomorrow. So someone needs to be assigned to these patients tomorrow. And if you happen to be the one that's on call overnight, someone needs to be on call because it's not going to be me.
Yeah, because it's different from like a floor nurse or where there's other people there that could pick up if you just quit, like, and you were like, I'm not coming today, I'm done, I'm putting in my notice, I'm sorry. There at least is options, or they can float somebody, but I think that case could be, there might be some other exceptions too, probably, that I'm not thinking of, but I would say there isn't necessarily somebody lined up, I guess, and those patients think you're coming. And so I think that's the difference there, I guess.
But that's a big one that is used as a threat, a scare tactic against nurses. Well, you have to give us 2 weeks notice. If you don't give us 2 weeks, that's patient abandonment. No, it's not. Okay. You might not be eligible for rehire because you didn't give them 2 weeks notice, but it's not patient abandonment, right? Refusing overtime beyond the posted work schedule.
Oh, many states that.
Yeah, that's a big threat, scare tactic. A lot of states stipulate that refusing mandatory overtime does not constitute patient abandonment. So they will say, look, you have to because you're the only nurse tomorrow. You're the only one. If you don't come in, that's patient abandonment. You're the only one, whatever. They're going to lie and manipulate you. That is not patient abandonment.
But they can write you up or fire you.
They can fire. This is the sad part. They can fire you for insubordination, for a lot of things, but it's not patient abandonment.
I hate that whole mandatory overtime thing. That just, that gets me. I mean, I know it happens everywhere and it's so frustrating. Or mandatory call, like mandatory something above your full-time hours. I think it's just.
Yeah, and you need to be familiar with the labor laws in your state because some states do address that and others don't. And some states, they cannot force you to have mandatory overtime. But some states have caveats for healthcare workers. So you really need to know your individual state. Refusing to give care that might harm a patient. We talked about that earlier. That's in fact our responsibility, our obligation as a nurse, right? If it's an order that you think will harm the patient, you not only can, but you should not do it. And that's not patient abandonment. And you need to document it. So don't let them tell you.
Unless you don't do it, but don't tell anybody you're not doing it. Yeah. That's how it gets construed into patient abandonment, as if there's something that should be done, even if it's you don't agree with it and you just don't tell anybody. So be careful with that.
Yeah. Refusal to accept an assignment that puts patients or the nurse at serious risk for harm. And that's actually from the AANA.
That's you. That's what you did.
Well, I think they mean a little more like physical violence type in this situation. If it is a situation where this patient is threatening your life, you can refuse that patient. And this is per the ANA. You should not have to be put in a situation where you are at risk for serious harm, or the patient is at risk for serious harm.
Okay.
That's not patient abandonment. Now, here's the big one that everybody wants to talk about, because you cannot have the conversation about patient abandonment without having the conversation of refusal of assignment. But refusal of assignment is not patient abandonment as long as you do it the right way. And this is probably the most common one, that they will threaten you with and lie to you and tell you they're going to report you. The thing is, like they did to me, anyone can make a report to the Board of Nursing. It's not going to necessarily stop them, but in the end, it will be in your favor. And I know it sucks and it's scary. I went through it, but it's not patient abandonment. If you are refusing an assignment and you're doing it appropriately for good reason, that is not patient abandonment.
And what we meant by doing it appropriately is what we described earlier. You can't take report from Susie, and then Susie's checking out and clocking out and leaving, and then you think about it and you're like, well, this is not good. Like I don't think I can handle this patient. That's your patient now. Like, you can't just say sorry. So you got to be careful.
And you need to try to, in those situations, try to collaborate with your charge nurse, your supervisor, whoever, and attempt some kind of an alternate assignment. Like, you should try to cooperate.
This episode is giving me anxiety because there's so much gray area. Honestly, like, you're describing this all, but to me, so many things overlap, like in a gray area, and that it's not fair. Like, honestly, it's not fair for healthcare workers, because I feel like, and it's state to state, it's blah, 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 but I feel like so much of it can get twisted to go one way or the other. Like, I feel like they're always throwing us under the bus, man.
Well, they are, of course. But here's what you have to remember. Once you accept the assignment, you have a duty to provide safe, competent care. That's it. And so it doesn't matter how inappropriate the assignment was. If you accepted it, you will be held to the standard of providing that competent care. It doesn't matter if you have 59 patients. And when you go before the Board of Nursing, because there's inevitably an adverse event, they don't care about your excuses or the backstory. They are going to ask you, why did you accept the assignment when you knew it was unsafe? And that's it. That's where it ends. None of the other stuff matters. You will be held accountable. So don't accept assignments that you know you're not trained for, you're not competent in, or that are unsafe for whatever reason, because you will be held accountable once you accept it.
But that's what I'm telling you, where that gray area lies, because somebody might start giving you report, and that's when you know what you're getting yourself into. I wonder if you say, no, don't talk any further. I don't want to hear the whole report. I can't. Like, I wonder if that.
I mean, I would, because I would then go to the charge nurse and try to get them to change the assignment. But ultimately, if they refuse, you've already started. You've got to go back. It's
horrible.
Terrible. It is. But another caveat that I don't think people realize when it comes to like refusing an assignment, nurse leadership also has a duty per the Board of Nursing to appropriately assign nurses and to appropriately staff units. And boards of nursing can investigate nurse leaders for failing to do that. The problem is no one ever reports them. But we can and we should. If nurse managers, charge nurses, directors, whomever is blatantly, knowingly making inappropriate assignments, failing to staff units, that's their professional responsibility in nursing leadership. That can be reported to the Board of Nursing. Yeah. But you know what I love? I love how they're always customers and clients until it talks about patient abandonment. And then all of a sudden they're patients and the patients need you.
Or, or you know what I love is the condescending, I've given this to you because I know you can handle it.
Yes, Cindy did that to me.
I picked you because I know of everybody that you can do this. Like, they butter you up, like, in a way that
it's patronizing and condescending.
And
you're the strongest nurse on the unit, Erica. You have more experience. You're the only one certified in this. You can take this patient. No, I can't.
I've heard all that crap. I've heard it all. Seriously, I really, really, really have.
Yeah.
It's awful. It's awful.
And I think it's also important in this conversation to point out that everybody needs liability insurance, because if you get reported to the Board of Nursing for patient abandonment, guess what? That liability insurance that's only costing you $100-something a year, that's it, is going to protect you. You're going to get an attorney from that. They're going to represent you if need be with the Board of Nursing. So every single nurse and nursing student, regardless of specialty and location, needs to have their own personal liability insurance.
Especially if you're saying it's only like $100, can be like $100.
I mean, depending on where you are, it's like $100, $150 a year, not a month, a year.
That's not bad.
It's not at all. It really isn't. Yeah.
To give you peace of mind and
So what do you think? That's what I had on my list. It's not all inclusive. And like I said, you have to know your individual state, your individual employer policy, the procedure for refusing, all of that. But in general.
And if you have a question about it, if something seems gray to you or vague, shoot us a message, shoot us a question, and maybe we can help you get the answer to it.
But don't ask me to look up your own state nurse practice act, because I've been inundated with those
Erica
requests.
blows a gasket on that. If you can find it yourself, don't make Erica do it. But if it's something worthy of us discussing, then sure. But no, we are not legal counsel as well.
No,
so
we are not.
We can only do our best here.
So save this episode, share it with other nurses that you know, because this is really, really important information. Share it with nursing students. This isn't covered enough in most nursing programs. This is important stuff. Be empowered. Okay.
All right, Erica, do we have an enema to give away this week? Not to Cindy, but to somebody else.
I wanted to do one just kind of in general, not to a specific person, but to nurses out there that are allowing yourselves to be manipulated and forced into doing things that you know are not within your scope of practice. Shame on you. You cannot tell me that you didn't learn, if you went to an accredited school of nursing, I don't care if it's LPN, RN, that you did not learn about scope of practice. There is no scenario in which I will believe that you don't know about this. All right. You know. So why you are falling for the charge nurse telling you you have to do it, you're the only nurse there, or the doctor telling you, well, I've ordered it, so it's okay, you can do it. Why you're falling for the manipulation and lies is beyond me. You damn well know that it's not within your scope of practice. Stand your ground and don't do it. If you are a nurse that has done that, and I've gotten a lot of these recently, this Enema award goes to you.
We're giving the nurse the Enema or the organizations?
Well, they both kind of deserve it in that situation. Although I will say, not necessarily the doctor. They're not responsible for knowing nurses' scope of practice. So they may say, thinking that they're correct, well, I've ordered it, so you're covered. But it's not their responsibility to know our scope of practice. It's your responsibility to know your scope of practice. Yours.
All right. So this could be a double-ended enema, or it could just be a single enema, however you want to look at it. But
it could be a suppository and a soap suds.
I think what Erica's trying to say, nurses, is be your own advocate, be your own fighter, because nobody else is going to fight for you, because they don't give a shit. They don't.
I'm sorry. They don't give a shit. And they'll throw you under the bus.
Okay. Well, this wraps up patient abandonment. We're going to abandon y'all and see you next week on the next Nurses Uncorked.